Hello, ladies and gentlemen. Welcome to 14th Young IFSO webinar. To all celebrating Eid, Eid Mubarak, Happy Eid. My name is Shahab. I'm Young IFSO APC representative and bariatric surgeon. I'm working at Fatima University Hospital from Tehran, Iran. So to start, I'd like to introduce my friend and colleagues all around the world accompanying me in this webinar. Dr. Wah Yang, Young IFSO President from First Affiliated Hospital of Jinan University, China. Dr. Mohammad Kermansaravi, Chair of IFSO APC Scientific Committee, Fatima University Hospital from Tehran, Iran. And Dr. Daniel Moritz, President-elect of Young IFSO from Medical University of Vienna, Austria. And Dr. Radhika Shah, Chief Bariatric Nutritionist at Laparo Apso Center, Mumbai, India. And Dr. Daniel Gros from University Hospital Zurich, Switzerland. And Dr. Alexander Nimark from Almazov National Medical Center, Russia. So, because Dr. Asim Shabir joined us later, so we jump to paper discussion with hot topic AI. And the topic is bariatric evaluation through AI. It's my pleasure to invite Dr. Amir Dawarpana, bariatric surgeon working at Fatima University Hospital, to present this paper, which was elected as a best paper of the month in obesity surgery. Amir?
Hello everyone, I'm Dr. Amir Davarpanah from Iran, Tehran, and today I want to explain about our published paper about bariatric evaluation through AI, a survey of expert opinion versus ChatGPT-4. It was published a couple of months before in obesity surgery. No conflict of interest. You can see here my mixture of operation in recent years. As you know, as you know, artificial intelligence evolved recently, and ChatGPT introduced in November 2022, and a study revealed that more than 77% of patients who was seeking for metabolic bariatric surgery, seeking their information among online references like ChatGPT. Recent study showed that ChatGPT can answer precisely and consistently for question regarding bariatric surgery, but use of ChatGPT in bariatric assessment has not been thoroughly investigated until publication of this paper. And in this study, we intended to evaluate ChatGPT answers and competency to detecting patient candidate for bariatric surgery and recommending optional and optimal operation type. For this purpose, we designed 10 patient scenario. Each patient scenario have one challenging item. And at the other hand, we asked ChatGPT to answer this question that is the patient suitable candidate for operation or no? And if yes, which type of operation should be choose? At the other hand, we gather 30 global surgeons from different parts of the world, only surgeons who perform all type of the bariatric operation. We did not include surgeons that are defending about specific type of bariatric operation. As I mentioned before, here you can see patient scenarios that we designed for evaluation. We asked this clinical question from ChatGPT in two separate period of time because we observed that ChatGPT answers will vary over the time. 30 well-known famous surgeons from 24 countries were included. More than 75% of them have more than 10 years of practice, 24% has less than 10 years of practice, and more than 86% of them have more than 1,000 bariatric operation in their history. The following 10 slides show 10 different patients that we designed for evaluation. In each slide and in each patient scenario, we put a challenging item. For the first one, persistent H. pylori infection. For the second one, history of gastric adenocarcinoma. For the third one, uh, biopsy-proven intestinal metaplasia in gastric biopsy, as well as a smoking habit. And the fourth question, patient was not a suitable patient for bariatric surgery. The fifth patient scenario was challenged by extensive adhesions due to previous endometriosis. And the sixth one, the patient has GERD and grade C esophagitis. And the seventh patient have severe GERD and also hyperplastic polyp in the fundus. And the eighth one has diabetes and reflux as well as COPD and use of BiPAP. And the ninth patient has the ectopic pancreatic tissue in the D1. And the last one has the Crohn disease. So we asked ChatGPT and expert panel to at first decide that is the patient good candidate for operation, or and if yes, which kind of operation can be choose for that specific situation. The challenging item in this scenario was a family history of gastric adenocarcinoma. Because we have only 10 minutes for presentation, I cannot explain each 10 patient scenario. But for example, in second one, we have a patient with intestinal metaplasia and also smoking habits. ChatGPT in both two questions, first round and second round, suggested rhinogastric bypass. But expert panel, more than 86% of expert panel choose a sleeve gastrectomy for such clinical situation. As you can see here, ChatGPT answers were varied over time in 4 patients and were consistent in 6 patients. And also you can see diversity of opinion of expert panel. In most cases, there is more than 60 or 70% of agreement, and in some cases, the answers were very wide. I will explain. As you can see here, we observe 40% of inconsistency between ChatGPT answer. It shows that ChatGPT answer will change over time. The next finding is that only 30% of answers were similar between ChatGPT and expert panel opinion, only in 3 cases. Also, ChatGPT was choose only 6 patients out of 10. 6 patients, either in 1 round or 2 round of answer. Only 6 patients was suitable for bariatric operation, but expert panel opinion achieved 90% agreement for performing bariatric and metabolic surgery for such patient. 9 out of 10 compared with 6 of 10. I summarize finding of our paper. You can find out the paper inside obesity surgery website. The limitation of our study was at first limitation of ChatGPT. ChatGPT 4 only have access to information before August 2021. So it was one of the limitation. And the second one is choosing expert panel. You know that some experts are defending about some specific type of operation. For example, one surgeon maybe have extra extra interest in extremely interested to sleep or extremely interested to OAGB or like this. So we didn't invite such surgeons. It was some criteria for choosing surgeons were involved in this research. We need some surgeons with international background and familiarity with artificial intelligence and a proven record of successful surgeries and good and substantial exceptional experience in field of bariatric surgery, and it is acceptable that there is no randomized method for choosing surgeons. It is one of our limitations. For take-home message, I should emphasize that ChatGPT has a potential role for patient education and also for consult with healthcare provider. Also, inconsistency between answer of ChatGPT over time should be considered. Another point is that for increasing accuracy of ChatGPT commands and answer, continuous collaboration between clinical experts and evaluating ChatGPT and other models of AI should be taken into account for more research and more development. Also, we can note that human expertise and personalized care activity play a cornerstone role in healthcare decision making, and current capabilities of AI is lacking. It needs improvement and it needs more collaboration with expert persons in this field. Thank you for your attention and hearing my speak and looking to my slides. This paper was published a couple of months before in obesity surgery, and for further information you can access directly to the obesity surgery website and see the paper. If any question, I'm here.
Thank you, Amir, for your nice presentation. Dear audience,
You're welcome.
if you have any question or comment, you can write in a question and answer box below. From panelists, any comment, any question? And dear Amir, I have a question. Do you think in the future AI and ChatGPT take place a surgeon? For example,
Definitely no.
For patient selection or for procedure selection in
Definitely
future?
no. I think that in the recent future, human intelligence never could be substituted with artificial intelligence, because many factors should take into account, and we checked it now more and more by ChatGPT. We know that AI doesn't mean exactly ChatGPT. ChatGPT is only a few parts of AI, and there is many other parts working. For example, in medical instruments and in equipment required for surgery, like robots or advanced tools for surgery. But I think for patient selection, for complication management, and for performing surgery, I think it is too far from us to completely remove the human intelligence from the medical field.
Thank you. Any comment? We have 5 minutes for discussion. Yes, Alex.
I think Daniel was first. Please, Daniel, comment.
Thank you. Just a quick question. So your study nicely demonstrated that the ChatGPT is not an optimal tool to evaluate preoperative patients' suitability for surgery. So what do you think? What's the current best integration of ChatGPT in surgical practice? Is it already ready to help us getting rid of some administrative burden, generating reports, op notes, discharge summaries, prescriptions, or what's your recommendation? How can we use it in 2024?
You know, the most limitation of ChatGPT exactly is that it is this platform doesn't have access to information published daily. It is finished off in 2021, and it cannot reach new information and new data that will be published or presented in conferences. So I think in 2024, only slightly we can rely on some features of this platform, but it doesn't work for medical consult. You know that there is some paper that ChatGPT passed ophthalmology board exam. You know, ophthalmology board exam of America was passed with ChatGPT, but we checked it in the field of bariatric surgery. It doesn't work. Its consistency was not good. He answered at the first time, Roentgen gastric bypass is a good option. 1 week later, no, the patient is not good for operation. You know, its consistency is not enough for this, and I think 2 or 3 more generations need to update the data of ChatGPT. Maybe Bard is better. Maybe other platform of AI may be better because they have online access for every information that's available.
I have a question about some. This may be for all of us, not only for Amir. As you told in your presentation, the human expertise, it's a key point for decision making, and we understand that it's always subjective. It's not objective. And what do you think? It's good or it's not good? Because the problem of choice, of decision making, it's always exist. And if we give it to the artificial intelligence, it's always give us possibility to be objective. But anyway, what is the best option for us, like medical doctors?
I should answer. You ask from everyone.
It's okay?
No answer. My own opinion is that, you know, yes, there is no selection bias for artificial intelligence. There is no any selection bias because it works with machine. That's it. But in this time, when I talk together, it's not enough. The intelligence of available artificial intelligence that we have now free access to them, I think it is not enough to substitute human intelligence and to decision making for selection of patient or for complication management or like this.
Hi, Amir. Can I have one more question? So,
Yes.
congrats to your great study. Is ChatGPT, or has it in this study also giving some explanation why one or the other indication or operation was chosen, or was it just it's Roentgen gastric bypass or no operation or?
Yes. If you see on the website of obesity surgery, there is an appendix file that in this appendix file, I entered all the answer of ChatGPT. It was not only yes or no, A or B or C. It has some explanation, and there is some logic behind the selection. All of them have, and I depicted some important notes of this logic on the discussion part.
Great, thanks.
Thank you.
Your microphone, Shahab.
So let's go to another paper. I'm glad to invite Dr. Radish Gadani, consultant bariatric surgeon from KD Hospital, Gujarat, India, presenting pregnancy outcome post-bariatric surgery. Dr. Gadani.
Hello everyone. I thank Young IFSO organizers for granting me this opportunity to present my paper. This is a paper on pregnancy outcomes post-bariatric surgery, the single-center retrospective study from India. My name is Dr. Radish Gadani and I am a consultant bariatric surgeon at Obesity Pediatrics, Ahmedabad. So this is my case mix. I do not have any disclosures. This is my team. We bring Wong ratings from India. Here we investigated the pregnancy outcomes of cohort of female with childbearing potential who underwent bariatric surgery at our center. The surgery was performed by a single surgeon with follow-up of 1 year post-delivery. The following aspects were investigated. Is pregnancy after bariatric surgery safe in Indian population who consume less protein diet? And the newborn outcomes post-pregnancy after bariatric surgery in Indian population of females, and outcome in terms of significant weight retention after bariatric surgery. This was a single center retrospective observational study. All female patients of childbearing potential between the age of 18 to 45 with any type of surgery who became pregnant and conceived were included. Patient lost to follow-up or incomplete clinical data were excluded. This is the data which we collected. In statistics, one way ANOVA was used. P less than 0.05 was statistically significant. So in a total of 1246 surgeries were performed during the study period. There were 847 females, out of which 220, that is 26%, were in the childbearing age group, and 34 females met our inclusion criteria. The mean age at time of surgery was 27.7 plus or minus 5. The duration from bariatric surgery to conception was 32.8 plus or minus 17.1. 25 females underwent sleeve, 7 underwent Roux-en-Y gastric bypass, and 2 females underwent one anastomotic gastric bypass out of 34. As you can see, mean preoperative weight was 107.9, mean BMI was 42.6, mean excess weight was 44.8, duration from delivery to date of surgery in months was 42.9. Weight at detection of pregnancy was at an average of 70 kilograms. Percentage excess weight loss at detection of pregnancy was 91.5. Weight gain during pregnancy was 14.9 kilograms at an average. Weight 1 year after delivery was 72.9 at an average. This is the comorbidity resolution. You can see approximately 70% of the comorbidities were resolved after surgery. Now coming to the pregnancy outcomes. Only 5 patients who had reported infertility, PCOS or both pre-bariatric surgery required assisted reproductive techniques, and the procedure included IVF, that is in vitro fertilization. Among the patients, 23 underwent lower segment cesarean section, whereas rest had normal delivery. No major complications were seen in any of the patients during delivery. 2 patients delivered twins. In gestational complications, no case of gestational diabetes or hypertension was reported. 2 patients had abdominal pain, 2 patients had anemia, 1 had hemorrhoids, 1 hypothyroidism, and 1 spotting. Now we compared outcomes based on weight at conception. We divided the patient into 2 groups, the G1 group, that is BMI less than 25, and the G2 group, that is BMI more than 25. Now if you see the comparison, if you see the rate of LSCOS, it was higher in G1 group compared to the G2 group. The neonatal complications were also higher in the G2 group, who had more weight at the time of conception. And the females not reaching original weight were also higher, that is 36.8% in G2 compared to only 20% in G1. In birth outcomes, 2 patients delivered twins. There were 3 preterm births and all the births were live and no baby had any congenital defects. 6 babies were admitted to ICU. The mean birth weight was 2.5 plus or minus 0.4. No baby was big for gestational age in this cohort. 6 babies were admitted to NICU for support. All 6 babies were admitted to NICU just for observation, as 2 were low birth weight twins. 1 baby for mother who had dilated cardiomyopathy, and 3 were low birth weight babies. No baby required prolonged NICU stay. Bariatric surgery is known to have positive effect on fertility of women and pregnancy outcomes. However, there are contradicting reports across different studies. Age plays an important role in fertility, and it is well known that there is a decrease in fertility with aging. The mean age of cohort at conception was 30 years in our series. The age at which the cohort is conceived majorly falls in lower to mid spectrum of reproductive age. Only 3 women were above age of 37 years. This may have been one of the factors for the success of spontaneous conception and comparatively successful results in this cohort. The ideal time for conception after bariatric surgery is at least 12 to 18 months post-surgery. Now, one study reported a comparable short-term perinatal outcomes such as congenital malformations or bariatric complications in patients who conceived within first post-operative year compared to those who conceived after first post-operative year. There were 2 cases in our cohort where conception was less than 12 months post-bariatric surgery. Although the pregnancies were earlier than recommended, the babies were not small for gestational age and did not require any special neonatal care. However, delivery was through LSAS in these cases. In maternal outcomes, no case of gestational diabetes or preeclampsia in this cohort was seen. Stone et al. Observed that if person was non-obese during conception, post-bariatric surgery, then they had a lower risk of developing hypertension during pregnancy, that is 8% versus 36.5% in obese cohorts. It has been reported that women who underwent bariatric surgery had lower rates of hypertensive disorders during pregnancy. In mode of delivery, there is higher rate of LSCS, almost 64% in our series as compared to normal delivery, and such observations have been seen in women who underwent bariatric surgery compared to the general population. The deliveries were done in different hospitals and there may be caregiver bias. Khan et al. In their review suggested that even though there may be no physiological reason, caregiver bias may contribute to elevated LSCS rate in women who had previously undergone bariatric surgery. Postpartum weight retention. Postpartum weight retention is known as weight change from preconception and first year postpartum. This includes the weight gain during gestation, early postpartum weight loss, that is 6 weeks postpartum, and later postpartum weight changes, that is after 6 weeks postpartum. The residual weight in cohort ranged from 3 kilograms to plus 20 kilograms post delivery. So women who reached original weight in 6 months were 38.2. In 1 year, 70.6% of women reached their preconception weight and 30% approximately did not reach their preconception weight. Now, what is substantial weight retention? Substantial weight retention is defined as post-pregnancy weight retention of more than 5 kilograms. In literature, there is incidence of 18 to 20% of substantial weight retention in normal cohorts. In our series, only 4 of 35%, that is only 11% had significant weight retention after pregnancy. No much data is available in literature regarding postpartum weight retention after bariatric surgery. In this paper by Laurent et al., they also showed that approximately 47.4 retain more than 10 pounds of weight and 24.7% of patients retain more than 20 pounds of weight after pregnancy. Regarding fetal outcomes, there are conflicting reports regarding the association of bariatric surgery with preterm birth. Some suggest that there is increased risk of prematurity in women who underwent bariatric surgery, and others report that there is no difference in risk of prematurity between women who underwent bariatric surgery and women who are obese. Maternal obesity and gestational diabetes are often associated with increased incidence of macrosomia, but there was no macrosomia seen in our cohort. This is a meta-analysis conducted by Zainab Akhtar et al. Regarding pregnancy after bariatric surgery and adverse perinatal outcomes. It included 33 studies and approximately 15,000 pregnancies. They show that there is increased odds ratio for perinatal mortality, congenital anomalies, preterm birth, NICU admissions, and small for gestational age babies. But in our study, this was not the case, as there was no congenital anomalies, perinatal mortalities, or preterm births. Coming to limitation of our study, it involved pregnant women who underwent bariatric surgery and did not have control group of obese women, and also restricted to a single center. To conclude, bariatric surgery improves fertility with safe pregnancy and its outcome in terms of preeclampsia, eclampsia, gestational diabetes, from postpartum hemorrhage, purpura sepsis in women with childbearing potential, and safe for offspring in terms of shoulder dystocia, macrosomia, birth asphyxia, and perinatal mortality. Bariatric surgery also protects females against substantial weight retention. However, they should be well aware of the risk associated with bariatric surgeries, especially the malabsorptive procedures. Thank you.
So thank you, Dr. Gadani, for your nice presentation. Very important issue, pregnancy after bariatric surgery. Any comment from the audience, panelist? Alex?
Thank you for your presentation. I have a question. Do you have in your experience, or maybe you look at this, the difference between sleeve gastrectomy and bypass procedure? How the delivering passing for that woman? It means the deficiency of the vitamins or something. Was more in the group of the bypass, or maybe less, or it's the same after 18 months of the procedures, because it's in this period the complete adaptation of the nutrition of the patient and microphone.
Yes. So at our center, if the female is like not married, we do not take longer limb lengths in women gastric bypass. We restrict to approximately BP limb of maybe 50 or 60 centimeters only. So within long term, almost it behaves as a restrictive procedure compared to a malabsorptive procedure. So in this cases also, those who underwent women gastric bypass and sleeve, there was no major difference in any nutritional complications or any protein malabsorption or anemia, because the limb lengths were not so higher.
Okay, thank you.
There is a question from the audience. Can we take that?
Sure.
Yeah. So the question is, was there any association observed in those who did not reach postpartum weight to preconception weight with rate of weight loss post bariatric surgery or any other specific factors?
Yes, the weight at conception was important. Those who had more weight at conception did not reach the preconception weight, and they had significant weight retention at the end of 1 year of post-pregnancy.
So I have a question from the panelist. Dear Mohammed, Dr. Kermosaravi, please tell us about the evidence and literature. Is there any cutoff for pregnancy after bariatric surgery, for example, for a sleeve gastrectomy or combined Roux-en-Y gastric bypass or other gastric bypasses? And some study concluded that even pregnancy less than 1 year is safe. And do you recommend, or another question, which kind of the contraception, mechanical or a drug, do you recommend? Dear Mohammed?
I think we should recommend, as usual, at least 1 year to 1.5 years after metabolic and bariatric surgery to be pregnant for the patients. There is no high-grade evidence to recommend that the patient can be pregnant before 1 year. Also, there are several studies that show the pregnancy before 1 year can be safe, but we can't recommend because of the low level of evidence. I think we should recommend the patients should have mechanical contraception, especially in the patient with gastric bypass, that the absorption of mini pills or OCP may decrease after the surgery. Thanks for your presentation. I have a question. I think that there is a big issue between the surgeons about doing gastric bypass or hypoabsorptive procedures in nulliparp patients, and they were afraid of doing any gastric bypass in nulliparp patients. But your study and the similar studies showed that it's not a big concern, and there is no risk for SGA or fetal abnormalities in gastric bypass. What's your opinion?
Yes, sir. So when a Roux-en-Y gastric bypass, if the limb lengths are not longer, usually it behaves as a restrictive procedure compared to a malabsorptive procedure. So we, in our center, as you have seen our case mix, we do a lot of Roux-en-Y gastric bypass, that too in nulliparous women. And we till yet not have faced major issues in pregnancy after gastric bypass. And that is why we have presented this paper also. So just we take care that we don't take long limb lengths and we close all the mesenteric defects, the mesenteric defect and the Peterson defect properly, so that the internal hernias does not occur. Otherwise, doing bypass in nulliparous women in our center, we feel that it is safer. It's not like more dangerous compared to sleeve.
Thank you. Dear Radhika, I have another question. You know, in some country, abortion is forbidden and illegal. And in case of pregnancy before 1 year, is there any consideration for the nutrition, for example, supplement or other issue? Please explain.
Yeah. So I think, am I audible?
Yes, yeah.
Yeah.
Yes.
So I think irrespective of pregnancy within 1 year, there should be certain focus on multivitamins given to this category of patients who are planning to conceive. However, if they are they conceive, I think sometimes maybe intravenous nutritional supplement can also be thought about for such patients, and special care in terms of supplementation, meal replacement, or what you say is concentrated meals. Small portions should be the focus, and highly bioavailable form of supplements should be the focus for these patients in concentrated meals, because large volumes and entire focus through the normal food or the regular meals cannot be achieved in such females. So maybe some dependency or maybe intravenous supplementation or injectable could be one of the options for supplementation in these females. And again, weight, in terms of weight, because there could be a weight loss challenge. So we have to focus on the quality of food consumed by these females.
Thank you. So,
are there any guidelines or consensus statement in your country about this?
Sorry.
Are there any guidelines or consensus statements set up in your country about this pregnancy after bariatric surgery, for example, from how
Yes, sir,
long?
the consensus is the same as guided by IFSO and ASAMBS. That is at least 12 to 18 months we have to wait before conceiving, and till that time we have to give adequate contraception so that the people do not become pregnant.
oh, thank you so much. We should go for the last but not least. I'm proudly invited Professor Asem Shabir, President of IFSO APC, to present enhancing bariatric surgery outcome through continued quality improvement.
Good evening. Thank you very much for the honored invitation to the Young IFSO Journal Club. I'm going to be speaking on enhancing bariatric surgery outcomes through continuous quality improvement. I am Asim Shabir. I'm the current president of IFSO APC chapter, and I work at the National University of Singapore. So let's try and see what quality in healthcare actually means. There are 6 core values according to the Institute of Medicine Committee on the Quality of Healthcare, and these are we should be able to provide safe, timely, efficient, effective, patient-centered, and equitable care. These are the quality core values that any institution or physician should be able to provide. So if we look at measuring quality, the first step in measuring quality is actually to accurately document quality and then measure the outcomes. And this is one of the key elements that we at IFSO uphold. And as you can see, we have published 8 global registry reports with large contribution of data from globally to benchmark outcomes and to know where the specialty of bariatric surgery is. Standardizing data on a larger scale to better analyze outcomes and benchmark current population results. How has measuring quality actually helped? We know that in higher volume centers, there is a 2.5 times decrease in mortality. In high-risk patients, where the mortality is increased, supporting surgery at comprehensive centers, which can effectively prevent futility, is important. You can see that in institutions that perform less than 15 cases per year, mortality rates in those above 65 years old was about 90% in the study by Flem et al. At 30 days and 21% at 1 year mark, compared to those who were younger than 65 years with a mortality of 2.2 and 5% at 1 year. So high-risk cases thus being operated in comprehensive centers is what we learned. We have long practiced perioperative care, and in one of the key elements is preoperative weight loss, which insurances companies mandate in order to improve outcome or perceived improved outcome. This is an evidence-based outcome from a registry that you can see. Time to surgery, if you institute insurance mandated preoperative weight management program, is delayed, versus those who do not join the program, they have their surgeries early. But does it really make a difference on excess weight loss, readmission, and reoperation? The answer is no. And this is how we get to know that how do we then proceed from here on in managing our patients, which means we can bring these patients, if we can do the surgery safely, to the operating theaters early. The United Kingdom's National Bariatric Surgery Registry also exists, and this includes a lot of parameters, including complications, reoperations, and readmissions in its own. And they publish their outcomes, and you can see in-hospital mortality for BAN being close to 0.00%, Roux-en-Y 0.05%, OAGB, MGB being 0.13%, and sleeve gastrectomy being 0.09%. Overall mortality of bariatric surgery being 0.04%. As we all know, MBS-equip has a long history of collecting data and publishing quality outcomes and helping improve focus on quality improvement. MBS-equip actually started with the American College of Surgeons in 2004, later taken over by ASMBS in 2005, and in 2015 it was formally named as MBS-equip. It basically emphasizes the role of a surgeon in leadership and multidisciplinary team, and defines and monitors the current bariatric center accreditation process. And I'll talk about accreditation in a minute. There are 6 core standards of accreditation. If you look at the last 3 standards, one is continuum of care under clinical education and protocol and long-term follow-up and available support at the institution. The second last is data collection. That means you are mandated to collect data to continuously improve quality in these patients. So Does implementing quality accreditation really help? They're core features of quality, and this MBSA equip actually deals with all three aspects, including structure, processes, and outcomes. And since it is pegged to reimbursement for the surgery, hospitals provide resources to maintain data collection, and this allows the care to be right-sited, so high-risk patients in tertiary care hospitals, whereas the others can be operated at other venues. So what impact has this accreditation actually had? Here you can see in Morton's paper that when you compare accredited to non-accredited centers, there is a reduction in reoperations, there is reduction in readmission rates, there is decrease in length of stay, and the cost of surgery actually comes down. But what is most striking is the reduction of approximately 50% of failure to rescue bariatric surgery patients. So those 50% of patients who ran into complications and would have passed away because they were managed in appropriate institutions, we could rescue them and they're still alive today. So that's the importance of looking at data and going back on data to improve quality. How has the benefit, how have we benefited from the MBSA equip data that has been collected and the quality improvement projects? This is one such benefit. You can see here, you can use this calculator, which gives you a 30-day risk of death, leak, bleeding, reoperation, readmission, intervention, any serious complication in surgical site infection if you key in all these parameters. So you can now tell your patients upfront that this is how your outcome is likely to look like. IFSO, as I said, this is, I think, the IFSO's 8th registry report that has come. Unfortunately, not very many countries here representing Asia. Malaysia is there, Australia is there, China is there, but many other countries, including my own very Singapore, missing from the graph. I think it is important that the young leadership at IFSO and ourselves look into this and continue to contribute, because it will not only allow us to benchmark our outcomes, but also to improve quality. And thus it is imperative that we contribute data to this. On the right-hand side of the screen, you can see unplanned return to operating theater. Great work by the South Koreans, as you can see, in Asia. And this is how we can continue to strive and learn from each other and improve quality. This was a paper that I picked up from the Annals of Surgery, and this is looking at benchmarking bariatric surgery. These are 19 high-volume centers with close to 40,000 elective bariatric procedures distributed between RYGB and sleeve gastrectomy. And they basically looked at primary patients who were rather simple, and they excluded very complex patients, because we know in these high-risk patients who have history of thromboembolism, diabetes, severe obstructive apnea, chronic kidney disease, immunosuppressive therapies, and other surgeries can potentially cause complications in these patients. And you can look at the benchmarks. The operation duration is less than 2 hours for a Roux-en-Y gastric bypass. Post-operative transfusion, less than 2%. Hospital stay, less than 4 days. And the cost is much lower. Mortality, readmission rates, 90 days readmission, less than 5.5%, and reoperation less than 4%. The composite complication index you can see here, which is a sum of multiple complications that may occur in one admission, is also given. And we can use these kinds of data to basically see where we stand in the bariatric community. What have other people done to improve the outcomes in their local society? And how can we learn and implement those to improve the care that we deliver to our patients? This is the paper looking at, the same paper looking at benchmarking sleeve gastrectomy. And you can see the outcomes again, phenomenal, less than 1.5 hours of operation duration, and complication rates again very low. A key take home from this slide, you can see here that some hidden things that then become apparent as we collect data. Abdominal pain of unknown origin in RYGB patients being the lead cause of readmission. About 5% of patients coming back. We know, and we talk about cholelithiasis, intestinal, internal hernia with intestinal obstruction, whereas in sleeve patients, the most common cause of readmission within 90 days is symptomatic gallstones. So we learned something from this, and we are now careful about abdominal pain of unknown origin in bypass patients. And this is how we use these quality improvement projects to improve the care that we provide to our patients. So in this realm of quality improvement, where we are studying clinical outcomes, there's one piece that has been missing and is finally gaining the attention of many of the researchers in our field, that is patient-reported outcomes. And this is a unique opportunity to monitor health-related quality of life at national level. And can this be used for? When we use this data, we can tell our patients, if you are so, and you go through such surgery, then your outcome can be potentially A, B, C, and this can help our patients make better informed decision about the care, about the surgery they want, and how they would want themselves treatment, as ultimately the patients are our biggest customers, and we want to treat them the way that they wish to be treated. So lastly, I would like to thank once again the Young IFSO Club for inviting me, and my emphasis goes without saying that I, as the president, would like to convey a message to APC and other people watching this webinar that please try and enroll into the IFSO registry so that we can make it valuable to collect information and then improve the quality of our own patients. With that, thank you very much, and have a pleasant evening, and I'll be around for any questions that you may have.
Thank you so much, Professor Asim Shabib, President
Hi.
of IFSO APC. Thank you for your supporting Young IFSO. Any question from panelists, audience?
Thank you, Asim. It was a very, very attractive presentation. I think all IFSO presidents should encourage all the colleagues to register their patient data in their national registries and then in IFSO database for progression of the science of MBS. Thank you.
Thank you very much. Yeah, certainly. So as a community, we would learn together, and that is progression. We learn from each other's experience and provide the best care to our patients, and that's what it will provide to us. So I hope as technique matures in Asia and across continents, I hope that we can also deliver to our patients good quality as well.
Thank you.
Thank you very much, IFSO, for hosting this great webinar. And I'm sure from the lovely presentations that we have heard on pregnancy and other issues, we will all learn. And the youngsters in this group are enticed and would come up more to present themselves to the greater community. So well done. Thank you very much, everybody.
Thank you. Any question, comments? So finally, I want to thank you again, audience, attendee, panelists, presenters. Thank you so much for your great contribution. And at last, I want to invite all participants, especially my young colleagues, to participate as much as possible for IFSO Melbourne, beautiful Melbourne. See you there. And thank you all. And also apply for a scholarship. Young IFSO, young colleagues. Oh, Daniel.
Yes, just last small comments before everybody goes away. I'd like to kindly advertise the participants and attendees to join us and follow us on Young IFSO LinkedIn site. This is our main communication channel at the moment. And I welcome any comments, proposals. We are happy to promote your publications, article, and that's the platform where we advertise the upcoming IFSO events. Thank you.
Thank you, Daniel. Good point.
Thank you, Daniel.
Everybody? Guys? Okay.
Thank you all.
Thank you. Have a
Thank
good
you.
time. See you. Bye-bye.